Thank you for inviting me to speak at this international conference co-hosted by both the Society for the Study of Psychiatry and Culture and the Fook Mental Health Association. The theme for this conference, Strengthening Cultural Psychiatry through Community Engagement, Social Connection, and Interprofessional Collaboration, has been my passion and life work. And I've been spending most of my professional life integrating effective approaches to psychotherapy that builds social connection, community engagement, and collaboration with faith leaders. So I would like to share my current approach, spiritually integrated, attachment-focused, systemic, experiential psychotherapy for building connection and resilience with Chinese individuals, couples, families, and groups in primary care mental health and faith community settings. So, of course, my background in both primary care, marriage and family therapy, emotionally focused therapy, and working in an ethnic setting and with faith communities has affected the development of my integrated approach. Now, our workshop is one of the last in the program, so I want to reflect on the cultural meaning of being last, which is very different in Eastern and Western cultures. And here I prefer the meaning of being last in Western cultures, saving the best for last. So we have two learning objectives today. First is to review the integration of Christian-based spirituality and Chinese culture into an evidence-based, attachment-focused, systemic, experiential psychotherapy model. Secondly, to consider applications of the integrated model in building connection and resilience with Chinese individuals, couples, families, and groups in both a primary care mental health and faith community settings. I don't have any disclosures. So I would like to use an actual clinical case, which is typical and representative of cases that you and I see every day, to highlight the 7 components of my integrated approach. Let's introduce our case. So 31-year-old Chinese male on ODSP with a part-time job. Family history is loaded, depression, bipolar, suicide, anorexia, psychosis, self-harm. So genetic vulnerability. He immigrated to Toronto as a teenager, and in the last couple years of his undergrad, he developed symptoms and started seeing a medical psychotherapist. And by age of 22, he consulted with a psychiatrist who diagnosed him with depression, became suicidal, and was hospitalized for 11 days with paranoid delusions. And he was discharged on venlafaxine, olanzapine, and also clonazepam. Diagnosed with major depressive disorder with psychotic symptoms, observed for psychotic spectrum disorder, and he came to me for further treatment and follow-up. So I looked at him, felt it didn't look like a mood disorder, so I refer him to see a Chinese psychiatrist who diagnosed him with schizophrenia, marked by poor insight, cognitive impairment, lack of motivation, severe withdrawal, non-responsiveness. He was fixated on guilt, ambivalent, and very indecisive. And the psychiatrist suggests family therapy, which we started monthly. And over the next couple of years, he had the opportunity to attend psychoeducation groups on self-esteem, on rebuilding his relationship with his parents, and also a faith-based DBT group. Now, with COVID, we switched to online family therapy and also group therapy using OTN. And by then, he had improved significantly in also the depression ratings, anxiety ratings, and relationship, and also self-esteem. So currently, he's fully recovered. He's engaged with his family. He's active at work and church. His parents are more responsive, and validating instead of invalidating, it's just giving advice. And under PHQ-9 and GD7, his scores are normal, subclinical. And I continuously see the family to build connection and resilience every 1 or 2 months. The first component in my integrated approach is connection and resilience. Both of these are key ingredients in mental health and well-being. We know this. Now, you need to ask how many approaches actually address both. So the table here shows the components of individual resilience and interpersonal connection. So let's get a sense of what this looks like in the therapy room. Okay? So with individual resilience, so the client says, I'm feeling more hopeful. I have more confidence and less self-doubt. I'm seeing myself as a competent person, able to manage my own emotions and be independent. The tightness in my chest and the weight on my shoulders have gone away. What does interpersonal connection look like in the therapy room? He says, I feel more comfortable sharing my struggles with my parents. I'm able to tell them what I need and let them know what is helpful or unhelpful when they respond to me. I feel closer to my father when he also shares his struggles with self-doubt instead of giving me advice. The second component in my integrated approach is effective spiritual integration. So here, the first multi-site study of the use of Christian-based spiritually integrated psychotherapy with East Asian Canadians was actually completed here in Toronto, showing the effectiveness of spiritual integration. And actually, our moderator for this workshop, Dr. Ellen Fong, was the principal investigator in this study. So it was a practice-based study with 24 therapists, 206 clients, and over 3,000 individual, couple, or group therapy sessions. So the clients, almost 70% identify as Chinese, and almost 95% identify as Christian. So we looked at the most common spiritual interventions, which were affirming trusting God, encouraging personal prayer, encouraging listening to the heart, listening to spiritual issues, and affirming the client's divine worth. We show positive clinical outcome with a decrease in psychological distress, relationship distress, spiritual distress, and therapy progress concerns. And this is what the use of spiritually integrated intervention looks like in the therapy room. Prayer. The client says, when something is bothering me, I'd like to ask my mother to pray with me, trusting God. My parents would encourage me to trust God instead of worrying about the bad outcomes and consequences. Fellowship. Sometimes sharing with my friends and counselor in my cell group at church is helpful. I don't feel as alone. The third component of my integrated approach is adopting an attachment focus, which integrates behavior, cognition, and emotions. I want to quote from Linser and Shaver. So, secure attachment as a style or habitual engagement strategy has been linked in systematic research to almost every positive index of mental health and general well-being outlined in the social sciences. So, a secure attachment bond in the therapy room is characterized by emotional accessibility, responsiveness, and engagement in parts of individuals, in partners, and in parents and their children. Emotionally focused therapy, the approach I use, restructures attachment, creating bonding events which promote emotional regulation and a healthy sense of self. So, as I explain this table, please reflect on how you feel when you are alone and when you are close. And this will help you determine your attachment style and the impact on your physical and emotional health. So people are secure with being alone and with being close. They have that secure attachment style. People who are secure with being alone but insecure with being close are self-reliant or avoidant. People who are insecure with being alone but secure with being close are support-seeking or fearful, anxious attachment. And people are insecure with both being alone and with being close are fearful, cautious, or fearful, avoidant. Now, this is a Canadian study associating the frequent, common health conditions that we see with the attachment style. The statistically significant associations are marked in red. So, if you're avoidant, you're more likely to experience arthritis, neck pain, back pain, headaches, chronic pain. Now, this makes sense because the negative emotions are manifested in the body when there is avoidance. If you're fearful or anxious, you're more likely to experience chronic pain, stroke, heart attack, hypertension, and ulcers. And when we look at depression, anxiety, alcohol, and substance use, secure attachment is protective, while avoidant and fearful of attachment are risk factors. Now, a crude indicator of attachment is marital status. The years of life lost to all the common cause of death are increased significantly in the never married group compared with the married group. Now imagine if you're fortunate enough to have a partner nagging you all the time. Put on your seatbelt, don't drive so fast, get your checkup, get your teeth cleaned, don't eat this. This has too much fat, too much salt, too much sugar, too much starch. Eat more fruits, vegetable, fiber. Don't drink, don't smoke, take it easy. Do your exercise, sleep earlier. All this nagging adds 11 years to your life. Since secure attachment is so important to both physical and mental health, let's look at what it's like in the therapy room. So, emotional accessibility. The son says, "My father has changed a lot. Before, I did not meet his expectation. He would get angry and then withdraw. Now he is present. He's trying to listen to and understand my feelings." Emotional responsiveness. He says, "When my parents can understand and validate my feelings and perspective, it gives me confidence. I no longer doubt myself and sink into regret over wrong decisions." Emotional engagement. "My father's used to giving me advice and telling me what to do. I don't want to listen to that kind of lecture. What really touched me is when my father can share the part of him that is not sure whether he is right, whether something is good. That makes me feel normal and close to him." The fourth component of my integrated approach is working with the whole family instead of individual. And let's talk about the history of systemic family therapy. Murray Bowen was a young psychiatrist studying families with a schizophrenic family member at the National Institute of Mental Health in the 1950s. Now, Bowen was curious as to how family member with schizophrenia get stabilized, they get discharged from the hospital, they go home, and then they relapse, they come back. And he recognized actually the behavior each family member affected all the others, and this research led to the development of systemic family therapy. With systemic approach, 90% of clients improve their emotional health. Nearly 2/3 improve their overall physical health. And with children, their behavior improved in 3 out of 4 of the cases. What does this look like in the therapy room? So the son expresses self-doubt and the father starts to tell him that the father has confidence in him and tries to assure his son of his competence, talking from his head. And the son turns away and puts his head down. And the therapist says to the son, "I'm curious about what is happening right here, right now. The more your father tries to reassure you, the more you disengage. Son, I'm tired of hearing him saying that. I still don't have confidence in myself, and I can't help my self-doubt. Father, I don't know what to say. I don't know if I'm doing the right thing. I just don't know what is good anymore. Therapist, let's slow down. This is so important. So what you're saying is that you also have a part that's not sure, that doubts yourself. Can you tell us more about this part? And the father does. And then the son says, when dad shows me this part that feels unsure, that doubts, I feel normal. I also feel closer to him. The fifth component of my integrated approach is using an experiential model, which makes sense of emotions. Nicole Freda is a Dutch psychologist who spent his whole life studying emotions, and this is his description of emotion. Emotion is not an irrational response or simply a feeling that accompanies thought. Rather, it is a high-level system that integrates a person's awareness of innate needs and goals with feedback from the environment and the predicted consequences of action. So there are important functions of emotion. It orients and engages. It grabs our attention and guides our perception. Secondly, it shapes our meaning making. Emotion is the rudder that steers thinking. Third, it motivates. And fourth, it communicates with others and sets up their response. So in the experiential therapy model that I use, emotional is the primary focus. It's also the target of change and the agent of change. So we're focused on reprocessing and regulating emotion. What does this look like in the therapy room? Where we help clients to make sense of emotion. So the son says, when my father offers his view and I don't agree, I just freeze. And then he gets upset because I don't respond and my whole body tightens up. Therapist, let me see if I'm getting this right. Part of you want to think this through on your own. Another part is afraid to disagree with your father and get him upset. And when these two parts are pulling in opposite directions, your body tightens up, but there's no movement like a tug of war. Does this fit with what you're experiencing right now? Son, yes, that's exactly what I'm feeling when I freeze and don't respond. And then he relaxes, puts his shoulder down, and exhales. The sixth component of my integrated approach is using therapeutic interventions that can be applied to many modalities, such as working with individuals, couples, families, and groups. So in emotional focus therapy, we use a EFT tango, which has 5 moves. We mirror present process. We reflect the interactional and emotional processes, creating and maintaining distress and disconnection. And we showed example in the previous slide, slide 20. Secondly, we assemble affect and we deepen affect. So we render alien, frightening, unacceptable emotions normal, human, understandable, and manageable. And we have an example in the previous slide. Thirdly, we choreograph engage encounters. We restructure attachment to create corrective emotional experiences, which we use to challenge the cognition, a sense of self, and to prime new behavior. Fourth, we process the encounter. We reshape a positive sense of self and sense of other. And fifth, we integrate and validate. We consolidate the positive changes. What does this look like in therapy room? Work at an individual level. The son says, I recognize my different parts inside me, including my fear of upsetting my father, my second-guessing and perfectionistic part, and the part that wants autonomy and space to figure things out for myself. the couple level. My parents are able to work together to support me instead of arguing and fighting with each other, which stresses me out. The family level. My parents are able to recognize my feelings and needs and respond with emotional understanding and support instead of getting frustrated or anxious. This helps me to relax instead of freezing. Working at group level. Seeing other families cope with similar issues and dynamics helps us to feel normal and encourage each other to work through these challenges. The seventh and last component of my integrated approach is building mental health care partnerships with faith communities. Systematic research in many countries find that religious coping is widespread. Meta-analyses show that religious improvement reduces depression, it speeds up recovery. Now, in view of overwhelming needs, meager resources, inequalities, and barriers to access mental health care, faith communities can make a powerful impact. This requires mental health professionals like you and I to build partnerships with local faith communities at multiple levels. And these levels are providing resources for and facilitating psychoeducation, training and supervising lay caregivers, enhancing pastoral counseling, and facilitating referrals to professionals. We have studied the outcome of psychoeducational groups in partnership with faith communities. We compare the participants' scores before and after a 12-week course on self-esteem, and we see significant improvement in self-esteem, in depression, in anxiety, and in relationship satisfaction. Same with our psychoeducational groups or couples with faith communities, also show significant improvement in all the dimensions of the dyadic adjustment scale. So what does this look like clinically? We'll go back to our example. So psychoeducation with groups and faith communities, our client says, the courses on self-esteem, managing emotions, and family connection provided practical tools that I'm still using every day. Support of lay caregivers. My cell group leader and fellowship counselor are very understanding, and I can share my struggles with them, and they will pray with me. Pastoral counseling. My pastor visited me when I was in the hospital and supported our family and continues to check in with us. Professional therapy. Emotionally focused family therapy has helped my parents to be more understanding and responsive. I can trust them to respond with support instead of telling me what to do. So, in conclusion, using a clinical case, we have shown how we can integrate Christian-based spirituality and Chinese culture into an evidence-based, attachment-focused, systemic, experiential psychotherapy model. We have demonstrated with case examples the application of this integrated model in building connection and resilience with Chinese individuals, families, and groups in primary care mental health and faith community settings. Thank you.